Welcome, everybody. This is the UCSF OSHA Research Seminar. We do these monthly, so this is our April session, and we have one more seminar after today's, which will be at the end of May, and we'll say a little bit more about it at the end, and then we'll take a summer break. My name is Ariana. I'm one of the research faculty here at the OSHA Center, and our talk today will be about the Lessening Incontinence with Low Impact Activity trial, evaluating pelvic yoga for urinary incontinence in diverse older women, with Dr. Alison Huang. Dr. Huang is a professor at UCSF in the Departments of Medicine, Urology, Epidemiology, and Biostatistics. She's the Director of Research for the Division of General Internal Medicine at UCSF Health, the Director of the UCSF Women's Health Clinical Research Center, and a clinical scientist dedicated to advancing understanding and improving management of the impact of aging on genitourinary health and women's health. She's designed and led multiple NIH-funded randomized trials of behavioral and integrative health interventions for genitourinary health conditions in women of diverse backgrounds, including the work she'll be talking about today. So welcome, Dr. Huang. And just for anyone who hasn't been at these sessions before, we'll have about a 45 minute talk and then take questions at the end. So you're welcome to put questions in the chat or hold your questions till the end. Go ahead.
Terrific. All right, I will share my slides. Okay. Can everybody see? Yes, terrific. Okay. So good afternoon. It's terrific to be talking today on behalf of our LILA study team about this work that we've been carrying out really for quite a few years now to develop and test and to evaluate a pelvic yoga program for women with urinary incontinence. So as Ariana said, I'm a general internal medicine physician in terms of clinical training, also a clinical epidemiologist and clinical trialist. It's been wonderful to collaborate with more than one OSHA-affiliated clinical scientist over the years, particularly on this LILA study. So I'm going to start talking not about yoga, but about the condition that our yoga program was designed to address, which is urinary incontinence. So some of you may know urinary incontinence is incredibly common among midlife and older women. At the same time, it's surprisingly under-recognized, underdiagnosed, undertreated. So I think most people, if you ask them on the street, would say, oh, how many women midlife and older have urinary incontinence? I might say, oh, is it 1 in 10 or 1 in 8 or 1 in 6? But it's staggering, really, that in research surveys, at least 1 in 4 women aged 40 years or older, up to half of women aged 65 years or older, report having urinary incontinence. And that's not just like, oh, whenever in your lifetime did you have urine leakage or once in a long while. It's really, on a weekly or more frequent basis. And, left untreated, urinary incontinence can lead to all kinds of problematic outcomes, right? It can increase depression, it can lead to social isolation, it can lead women to avoid physical activity and develop more functional decline over time. It's been linked with falls and fractures. And then, among older women, it can really be a major factor that leads women to lose their ability to live independently, right? It can be the straw that breaks the caregiver's back that leads women to transition to long-term care facilities. And so it's not surprising that, we think that the direct costs of urinary incontinence among women in the US may be greater than actually the combined costs of breast, uterine, ovarian, cervical cancer combined. But at the same time, less than half of women who have ongoing urinary incontinence are receiving any kind of clinical treatment. So there are probably a variety of reasons for this. Some of it may be the stigma that's associated with problems with bladder control or continence. Women, the usual statement is don't ask, don't tell. Women who have the symptoms are afraid to bring them up with their healthcare providers. Healthcare providers don't think or don't have time to question their patients about urinary incontinence. This came up for me earlier in my clinical training where, I had inherited a panel of patients, Chinese American patients as a resident in UCSF General Internal Medicine. And I had several encounters where my older female patients, when I would ask them about anything they wanted to talk about, they would say, oh, nothing special, nothing special. And I'd get through my checklist of other kinds of screening or other items. And then at the very end of the visit, my patient would pull out a pad or a form or script asking for me to sign authorization for incontinence pads or diapers. And it would turn out that they'd had this problem for years and years without, getting any other kind of treatment. And at first I thought this was an issue specialized to Chinese American women. Chinese American women have so much more incontinence, but nobody knows it because they can't communicate with their healthcare providers. But as you may realize, and as I later realized, conducting other research, it's not unique to Chinese American women. Women of all racial ethnic backgrounds, midlife and over, have a high rates of urinary incontinence, but it may be only 40% of women have ever sort of discussed this with a healthcare provider or believe they have discussed it, and fewer still who are actually engaged in any other kind of traditional healthcare treatment. So, part of the reason for this might be that there are some troubling limitations of existing treatments. So first-line treatment for most kinds of urinary incontinence women is supposed to be behavioral. That includes sort of bladder retraining exercises, pelvic floor muscle exercises, and these can be very effective, but many women have difficulty learning how to practice these with just sort of routine teaching by general practitioners. And even if they do learn how to practice it, they can't keep up the practice over time. Now, for some kinds of urinary incontinence, for example, urgency incontinence, where women have sort of sudden or strong urges to use the bathroom and kind of rush to the bathroom but can't get there in time. For some kinds of incontinence, there are medications, and those are modestly effective in improving incontinence frequency or severity, but they do have multiple potential side effects. And studies have suggested that at least half of people who start these medications discontinue them within a year. And then, there are third-line procedures, surgical or invasive treatments, and again, they could work for the right women, but they can have post-procedural complications. Some of them involve longer recovery time. They're not always appealing to women, particularly older women, I'd say, who have some of the worst incontinence. And really all of our clinical treatments are also targeted usually at sort of one specific physiologic contributor or organ-specific contributor to incontinence. But we have reason to believe that as women age, bladder control problems aren't usually caused by just one sole anatomic or physiologic defect. The origins of incontinence is more multifactorial. So it's not just that women have, say, more weakness of the pelvic floor supporting the bladder that can result in more, say, stress type incontinence with like pressure on the pelvic floor or bladder. Not just that they have, more autonomic nervous system function that's, been linked with bladder muscle overactivity, not just more, abdominal obesity, putting more pressure on the bladder, not just, superimposed physical or cognitive functional decline. It's that they have all these things, simultaneously. And it really suggests that, we need treatment approaches that are, more pleiotropic treatment approaches that can address simultaneously multiple potential aging-associated contributors to problems with bladder control. And also there's just the fact that, our current incontinence workforce, if you say, like the workforce of urologists and urogynecologists and pelvic floor physical therapists, it's just simply too small to meet the needs of the vast number of women with urinary incontinence in the community. Really, we needed an entirely different model of care or approach to managing this issue. We need, greater emphasis on self-management of this issue when it's an issue that affects, at least 1 in 4 women midlife and older, and up to half of women in the older age range. And, we do see in studies that many women with incontinence are seeing complementary health providers, are trying complementary treatments, although in many cases they're trying treatments that are not known to be effective, may not be effective, or at least haven't been evaluated well. So one complementary treatment approach or managed approach that's been recommended for women with urinary incontinence is pelvic yoga, pelvic floor yoga, might also be called. And so, we can think of multiple reasons why yoga might be beneficial for women with urinary incontinence, particularly older women with incontinence. First, I'll just say, Hatha yoga, the largest branch of yoga that involves the practice of physical poses or asanas, that's been used by many practitioners to try to improve or maintain physical strength and conditioning. And so, regular practice of yoga may help address physical deconditioning as a potentially modifiable contributor to incontinence in older women. And then, some styles of yoga, for example, Iyengar yoga, put a fair amount of emphasis on kind of awareness of specific bodily structures during the practice of poses. And it's just that, this kind of approach to yoga could help women become more aware of and develop more control over, let's say, the pelvic floor muscles, which support the bladder. So that yoga could be almost a kind of complementary substitute for traditional pelvic floor rehabilitation therapy. And obviously, yoga approaches that involve deep breathing, more mindful awareness during the practice of poses, these have the potential to help women control or improve perceived stress and associated stress reactivity, which has been linked to sort of overactive bladder, greater bladder muscle contractions, and urgency type incontinence. So really, there's multiple potential ways in which we might suspect that regular practice of the right kind of yoga techniques might be helpful for women with this problem. And, of course, we all realize that pelvic yoga, it could be made available in the community in a way that could really help with issues with access, right? Women could practice yoga, not, without having to go to sort of repeated costly one-on-one visits with clinician specialists. They could access yoga in community settings, in senior centers, in yoga studios, in other community centers. Yoga instruction could be delivered in groups rather than sort of one-on-one individual therapy. And, the fact that yoga is sort of framed in any other context as sort of a wellness activity and has the benefit of that kind of, I guess, positive marketing as a wellness activity could be helpful, if it's directed at a condition that carries a fair amount of social stigma, like incontinence. Women who might be reluctant to say, oh, yeah, I'm going to my pelvic rehab session for my urinary incontinence, might feel differently about saying, oh, yeah, I'm going to my yoga for pelvic health class. Now, yoga is already being practiced by many women with urinary incontinence or other pelvic floor disorders or other pelvic health conditions in the community. If you, Google yoga for pelvic health or yoga for urinary incontinence, you'll see all kinds of workshops and classes and books. Unfortunately, until recently, none of these yoga practices were supported by any real evidence of efficacy. And, as similar to, I guess, probably sort of yoga marketing in the US at large, these kind of classes and workshops and books, they tended to feature pictures and images of young, healthy, athletic women. They did not tend to show pictures of women who were older, more likely to have multiple chronic conditions, more likely to be overweight or obese or be frail or susceptible to injury. And, obviously that's the typical woman in yoga advertisements is not necessarily the typical woman who has urinary incontinence. So it's, reasonable to sort of say, oh, gosh, not only do I wonder if yoga is going to be effective for urinary incontinence, but is it even feasible or safe for women who tend to have incontinence in the community? So, this was kind of the inspiration for a series of studies that our Women's Health Clinical Research Center spearheaded with a partnership from folks at Osher, including Margaret Chesney, with urogynecologist partners, Leslie Subak, who used to be at UCSF and is now at Stanford, obviously yoga consultants from the community, physical therapy consultants, and others, with a focus on sort of aging and geriatrics research and care. So it started with this Lessening Incontinence by Learning Yoga pilot trial, which was a small pilot randomized trial in midlife for older women that involved randomizing women to either twice weekly group yoga classes, reinforced by sort of once weekly practice outside of class for 6 weeks, or what was essentially a kind of waitlist control program. So receiving no initial yoga instruction, but getting gift cards for yoga classes at the end of 6 weeks. And I'll say, both groups in this pilot study also leave some basic written information about first-line behavioral self-management of incontinence, of the kind that you might get, at a primary care visit or see online, something that all women should have access to and could easily get access to, right, if they're aware of it. So participants in this initial study, they could be as young as age 40, but there was no older age limit. They had to have at least daily urinary incontinence symptoms, urgency type, stress type, or a mixture of these types. There were some minimum mobility requirements. So women did have to be able to walk at least 2 blocks on level ground, to be ambulatory, and also to be able to get from a supine position to a standing position. They could do it slowly, but they had to be able to do it on their own. We wanted a relatively yoga naive population, so the participants could not already be engaged in any kind of organized yoga classes or yoga workshops or training. And they had to be willing to forego any sort of formal behavioral or pharmacologic or invasive treatments for urinary incontinence during the study. And at first, we did also leave out women who had more complex urologic history. So that did include women who had a history of urologic cancer, surgery to the bladder, known sort of fistula between the bladder and the rectum, urinary incontinence due to a major neurologic condition. So it was women who had relatively uncomplicated urinary incontinence. So the pelvic yoga program, which was designed by a panel of sort of expert yoga consultants, that the lead consultant was Leslie Howard, and has been a terrific partner in this research and other research. And it incorporated sort of standard hatha yoga poses. It was informed by Iyengar style yoga. So, there was attention to kind of postural alignment and awareness of different body groups during the practice of poses, attention to breath work during the practice of poses. I will say overall, I think the program did put more emphasis on these kind of physical components, less attention to some of the sort of maybe emotional or mental or spiritual domains of yoga, for better or for worse. It incorporated yoga props like blocks and straps and bolsters to minimize risk of injury, to accommodate participants who might have lower flexibility at baseline. And, then, in twice weekly 90-minute group classes, led by a study instructor who's trained by the expert consultants, women were introduced to the different poses and techniques. And then they were also encouraged to practice what they learned outside of class for at least one time a week, using a kind of printed manual that included instructions on how to practice the poses, that included pictures. The manual and the group instruction, included tips for performing poses sort of as safely and comfortable as possible, including how to adapt poses using common props. And also include some tips for sort of trying to tailor the practice of poses to women's pelvic floor function, like to help women become more aware of the pelvic structures and how that might be relevant when they practice like some of the first line behavioral strategies like pelvic floor muscle exercises to manage their incontinence. And the materials in the manuals and the pictures, they were really designed to be sort of accessible to women across a range of ages, racial or ethnic backgrounds, and body types. And so, just to mention, this is a picture that wasn't used in some of the later versions of our manual, but what was used in an early version. It's actually a picture of my mother. We were aware there are so many Asian women in the Bay Area. We didn't have a model or picture of an older Asian woman at first, and my mother, bless her heart, even though she had never practiced yoga in her life, was willing to be photographed in our living room in her long underwear, doing a simple chair pose. So, adherence to the group classes was quite good when considering we were taking a bunch of women who had not been practicing yoga before or really engaged in anything like this before. All of the women who were recruited attended at least 11 out of the 12 recommended group yoga classes. A little over 2/3 attended all 12 classes. When we're asked at the end of the program to sort of rate their confidence in performing all of the yoga poses they had taught, they were all, at least moderately confident in practicing all those poses, although it was really only a little more than half who said, oh, I'm very confident in my ability to practice all of the poses. And one of our expert yoga consultants did sort of observe all the participants in their last yoga class. So, just silently watched them and then did a simple sort of ratings of how successful participants appeared to be in performing their poses. And they were all judged to be at least moderately successful, but, a little under a quarter were very successful in all of the poses. And then, in terms of urinary incontinence symptoms, so just obviously what was the motivation for the women and for us, we do. Changes in frequency of urinary incontinence were evaluated using voiding diaries, bladder symptom diaries, in which women recorded each time they experienced urine leakage or used the toilet over a week-long period. And you can see from this graph that over 6 weeks, the pelvic yoga group reported an average decrease of more than 13 episodes per week. So that was sort of about a 66% reduction from baseline for them. Whereas the weightless control group on average reported a decrease of maybe just over 2 episodes per week, which came out to more like a 13% decrease. And even in this very small sample, the between group difference, met the traditional threshold for statistical significance, and everybody was delighted. In some ways we would have liked to have been done there, or certainly felt encouraged by the evidence of benefit associated with the pelvic yoga program. But of course, we couldn't be done there. It was quite a small participant sample. All of them were recruited from one study location, UCSF, a relatively short duration of intervention and follow-up. And there was really only one instructor teaching the classes. And so, not clear if this is something that could be duplicated across multiple instructors. Also, as I'm sure many of you are aware, the fundamental design of that trial with a weightless design, weightless control design, was a pretty weak design. Weightless controls can give rise to a fair amount of bias in outcome reporting when participants have very different expectations of the benefit they're going to get from being in one group or the other. That may not be true for all kinds of outcomes, but it's certainly true for outcomes that depend on participant self-report. And that's certainly the case when we're expecting women to report their own urinary incontinence episodes to us. And then there's just the issue that when it comes to an intervention like yoga, we don't just care if there's benefit associated with yoga. We care, why is there benefit, and is that benefit really unique to yoga? We take a group of older women not engaged in physical activity. Is it possible that they'd get much of the same benefit from engaging in some other kind of exercise, some other movement-based activity? So, these issues, these questions led us to move on to really 2 follow-up trials, although I'm going to focus on the most recent one that we recently completed. So these were multicenter randomized trials in which women were randomly assigned to either pelvic yoga program, really similar in format and in most of the content, although a little longer, now going on for 3 months rather than 6 weeks. Or they were randomly assigned to what we called the physical conditioning program. So this was involved time equivalent group classes and time equivalent individual practice of sort of general skeletal muscle stretching and strengthening exercises. And once again, both groups received usual self-management pamphlet, sort of first line basic behavioral self-management strategies for incontinence. And in this trial, I can't go into depth about everything, but the primary outcome was really change over the 3-month intervention period. But there were plans also to sort of sound out women another 3 months after that, and another 3 months after that, just to check, like, oh, once your intervention classes stopped, have you continued to practice your yoga or your other exercises, and to just get a sense if there are any improvements that were seen earlier on, do they persist? So, about this physical conditioning program, so the focus was on upper and lower extremity stretching and strengthening exercises, designed not to require a whole bunch of equipment, really only exercise straps and handles and exercise mat. There was a desire to sort of avoid exercises that would strongly engage the pelvic floor, although there was a squat exercise that could have some engagement of the pelvic floor, and again, designed by a physical therapy consultant or partner in this research, Sarah Pawlowski, to sort of be feasible and safe for ambulatory women across the aging spectrum. And again, group classes and written manuals, provided instructions and pictures of how to practice the different exercises. And the materials, were designed, again, to be welcoming of women across a range of backgrounds and ages and body types. So, it was important to us that participants in both groups felt like they were engaged in an intervention that was potentially beneficial. So in both groups, there was an explanation for why the intervention might be expected to be helpful based on, what's known about contributors to incontinence. And after the participants got their sort of brief introduction to what the intervention involved, they were asked a series of questions to sort of gauge their how credible they found the interventions to be, what their expectations were of treatment. Include, questions, rate on a scale of 0 to 9, how logical do you think the treatment that's being offered to you is? Like, how successful do you think this treatment will be in reducing your urinary incontinence? And I'm glad to say that both groups had really similar ratings of credibility and expectations at the beginning of their programs. Whether you were assigned to the pelvic yoga group or assigned to the physical conditioning group, you had a sort of similar sense of potential benefit to be associated with your treatment design. So we started this research before the COVID pandemic with plans to deliver all of the instruction in person, through brick and mortar yoga studios or exercise studios. But when we were, maybe about a third of the way through our recruitment, the pandemic came on, shelter-in-place orders were issued. They happened to be issued at quite an inconvenient time for our study, I have to say, because this was a study because we deliver the intervention in groups. We don't want to randomize women until shortly before a group class series is designed to begin. It meant that our approach involved basically recruiting, screening women for months across multiple locations in Northern California for this most recent trial, and then randomizing all of the women in that wave sort of en masse within a 2-week period right before the start of group classes. And unfortunately, shelter-in-place orders were issued right as we had randomized an entire wave of participants across all 3 locations, and were about to start classes, or in some cases had started the first class for a cohort. So it left the prospects of potentially a massive dropout of all of those participants. But instead, we shifted intervention instruction to video conference, to Zoom. I wish I could say that we were able to do it in a slow, thoughtful way at first, but it was quite a rapid scramble. And then, fortunately, I think we were able to do it more thoughtfully in the waves that went after that. So from then on, participants engaged in their interventions in video-based classes. They were still live synchronous classes involving, instructor and a group of women just assembling together at the same times, and they were interactive. But I would say it did take some time to try and figure out how could we guide and support women engaging. And we did lose a few women, considering we were dealing with women across the aging spectrum. There was that first wave, there was a woman who didn't have an email address, had never used email, and just was not able to take part by video. But we were able to save the great majority of participants, even in that first wave. So of the over 480 women who were assessed for eligibility, 240 eventually were randomized across all of our waves. About 2/3 of those ended up being in waves that involved primarily video-based instruction. And, 88% of the participants were randomized, completed their 3-month interventions, and provided outcomes data through bladder symptom diaries to evaluate their incontinence. So the median age was only about 62 years. The oldest participant was 90. And we had women from, a variety of different self-reported racial backgrounds, more Asian women, perhaps than any other group, but maybe representative of what we might see in the San Francisco Bay Area in an older age demographic. So women had quite frequent incontinence at baseline, like on average, we were reporting 3.4 leakage episodes per day. These were women who'd had incontinence for quite some time. So, the majority of participants had had incontinence for 5 or more years before they entered the study. And, they had a variety of different chronic health conditions, as you might expect from an ambulatory older population in the community. Many of the women met criteria for obesity. They might have chronic respiratory disorders, they might have arthritis. So I spoke a little bit before about how we were assessing women's expectations of the treatment groups, how logical they thought it would be. When we looked across age groups in the yoga group, we didn't see any significant differences in how logical the pelvic yoga program seemed to participants in the beginning. And maybe there was a little bit more of a trend to differences by age in how successful they thought the treatment would be. There it was really that perhaps younger participants were a little bit less likely to think that the yoga program was going to be helpful to them. And then, we also looked across some broad ethnic categories. So, as I'm sure many of you know, yoga practitioners in the US are disproportionately sort of non-Latina white. And we were concerned, like, even though we were trying to make our materials sort of accessible to women from different backgrounds, for example, we didn't have any yoga class instructors who were Black or were Latina. And so, we had a sort of group of primarily non-Latina white and Asian instructors. And we sort of just looked broadly, oh gosh, like how logical, how are people perceiving our program based on their broad background? And these are kind of collapsed partly for numbers, but sort of looking at if you self-identified as Asian, as you self-identified as having any Black, Latino, or American Indian ancestry as groups that sort of identified being underrepresented among yoga practitioners and definitely yoga instructors, or if you self-identified primarily as non-Latino white. So if we saw any differences, it was actually that women from underrepresented backgrounds thought that the pelvic yoga program was more logical, actually, in terms of as approach for managing incontinence. And we didn't see any important differences in how successful women in the pelvic yoga group thought the treatment would be based on their self-reported ethnic background. So considering that this was, again, a group of women who were being asked to really perform a major behavioral change, right? But they were not already engaged in yoga. They were also not engaged in any kind of general, regular physical muscle conditioning exercise. Attendance in the group classes over 3 months was pretty good. So over 90% of the participants, who, if they didn't drop out before the end of 3 months, over 90% of those participants completed at least 75% of the group classes. And the majority indicated they were also completing their recommended individual practice hours. So, we in the middle of the study did think to say, oh, we've started teaching yoga online. This is a very different approach than what we anticipated. What was the experience of participants in these on yoga classes? So this is something that one of our collaborators, Francesca at Nicosia, is exploring more in depth. I'm just sharing a little bit here now that participants in the group yoga classes that were conducted all by Zoom did tend to have good feelings about how their ability to see the instructors, share their thoughts, the convenience, but did definitely discuss sort of the decreased sense of personal connection with other participants, which was one of the things that we did think of as a benefit for women incontinents who might otherwise be more isolated. And I do remember one participant, in fact, saying, oh, I thought this study was how I was going to make friends in San Francisco, because she had moved more recently to San Francisco. And unfortunately, that didn't turn out to be the case for her when it was all converted online. It's not to say that we didn't have some concerns about safety or feasibility for older women. I remember a scary episode where I got a text from one of our clinical research coordinators, and I think it said something like, participant with fracture, tripping and falling during, and I thought, oh God, if we have even one fall and fracture from this program, it doesn't matter if we cure women's incontinence, we'll never want to continue this line of research. Fortunately, it was not somebody who actually had a fracture. They had an old fracture that had healed, but there was like a flare-up of pain at that site. They had not tripped or fallen while practicing yoga, fortunately, but it was somebody who had sort of maybe left her yoga props spread out over her living room and did trip over them walking across the room one day. And really, actually, it shows the sort of complex ways in which we have to think about the effects of sort of physical intervention activities. I mean, when we do home safety evaluations to reduce fall risks in older adults, clutter in the home is one of those fall risks. And so this led to sort of different instructions and handouts saying, put your props away when you're not using them. Don't leave your props on the floor where you can trip and fall over them. We think of the group classes as providing an opportunity for participants to interact and socialize and support each other. And in many cases it was, but interpersonal interaction can have its downsides as well as positive ones. So sometimes the participants didn't all get along. And, there's one for me memorable episode where, there was a concern raised by one of our clinical research coordinator who was following up with one of our Black participants. And, that participant had said, I'm the only Black woman in my class, and there's another woman who often comments on what I'm doing and my exercises, and I feel like she doesn't like me that much, or her comments are a little combative, and I think it's because I'm Black. I'm the only Black woman in this class. And it led us to investigate more, and concerned led us to lead to questions like, oh, are we providing any information about code of conduct, or how do we handle what our expectations are for our participants' behavior during these classes? And we talked more with the instructor for that class, who sort of noted, I think I know what other participant is that your Black participant is talking about, that there's another participant who is a white woman. She's also the only older woman in that class. Like most of the participants in this class are kind of more in the middle age range. This is the one older range, and she's not very strong or as flexible. And when she seems to also be very insecure, like sometimes we have to stop and help her out a little bit more. And then she often makes comments about how other people, seem to be doing it differently than her. And the constructor had some sort of thoughts or insights into how the different concerns and feelings of isolation and insecurities of different participants were kind of playing off each other. So just recognizing that group interactions can be complex, and we think of them as often offering benefit, but they can offer downsides as well. And then I'll just say, just interesting insights came from the fact that we were, inviting women in the second half of the study to participate online, and we then see into their homes how they're trying to practice at home and some of our instructors would reach out to say, I think some of the women in my class are hoarders. They're practicing in some like closet-like space, and there's like tons of stuff all around them. And there were, people, we couldn't really necessarily find privacy in their homes. There was one participant whose husband with dementia, she couldn't really leave him alone. He would kind of frequently wander into the view or interject comments into the class that could be heard over Zoom that weren't necessarily always appropriate. So this is just the challenge of when yoga isn't being taught in a studio, when people's own homes become their studios, then we deal with all the challenges of the home environment. So, overall, we did think that the programs were safe. So a variety of adverse events, were reported. This did include a certain number of musculoskeletal events, things like, oh, muscle strain, or my knee hurts more, or, I like my shoulder aches ever since I started my first class, or my shoulder aches, and I don't know if it's related to class, but it does hurt more or something like that. But we didn't see differences across the two groups. And the one sort of serious adverse event that we detected, which was kind of a hospitalization for a cardiac type issue, we didn't have reason to think it was related to either intervention. So, at the end of the program, women were asked to sort of rate their self-confidence, their self-efficacy in performing different yoga postures and techniques. This, again, is something that Francesca Nicosia is exploring in more depth. Just say that, if we just look superficially at the respondents by age group, we do see some signs that women in the older groups, may have felt less confident in their ability to execute all of the yoga poses. We didn't see any meaningful differences in self-efficacy in performing poses by ethnic background. And, of course, there's how women report overall in their ability to practice yoga poses, but there are obviously difference depending on the pose. It wasn't surprising to us to see, oh, well, if we see who felt very or extremely confident in their ability to perform corpse pose, savasana, that we 100% of the women felt they could execute corpse pose, but not as many for triangle pose, for example. So in terms of urinary incontinence, again, which was really the point of the study or the motivation for most of the women. So once again, if we look over a 3-month period, average urinary incontinence frequency of any kind decreased substantially in the pelvic yoga group, more than 2/3 improvement from baseline. But there was quite a bit of improvement in incontinence in the physical conditioning group as well. But more than 50%, which is often the standard that's described as kind of the threshold for clinically important improvement in women who start out with these daily incontinence. And in multivariable models where we're looking at change from baseline to both 6 weeks and 3 months, and we're controlling for study site and baseline incontinence frequency and the predominant clinical type of incontinence that women had, clustering within groups and by instructor example, the difference in improvement in any type urinary incontinence frequency was just short of the usual threshold for significance. We did see modestly greater improvement in urgency type incontinence frequency in the pelvic yoga group versus physical conditioning group. But you could argue that that difference, even if it was significant, was not that clinically meaningful or important. And really, changes in stress type incontinence frequency were very similar between groups. And so looking at sort of some common questionnaires that are used to assess incontinence-related quality of life, genitourinary quality of life, some modestly greater improvements in scores on the Urogenital Distress Inventory 6 questionnaire with the yoga group versus the physical conditioning group, but no significant differences in some of the other measures. And really, like, scores in all of the measures improved by more than what is usually considered the sort of minimum clinically important difference threshold. It's like more than 11-point improvement in Urogenital Distress Inventory 6, 16 points on its impact questionnaire, for example. So just thinking a little bit further out from time. So, we had pretty good retention of participants during the 3-month interventions. When we sort of reached out back to women at 6 months or 9 months who had no longer been engaged in yoga classes or physical conditioning classes, we had quite a bit more dropout. And we think that women who didn't respond to us or didn't want to provide more follow-up data were more likely to be women who ceased to practice their interventions much at all. And this sort of similar kind of trends we do see in terms of between group, both within group improvements and trends towards within group difference in associated with pelvic yoga or physical conditioning, but differences between groups did not become more significant when we look at the sort of 6 or 9 month point as opposed to the 3 month. So this was a study with a variety of limitations. One, of course, an important one of the change from in-person instruction to primarily video conference-based or virtual group instruction. You could argue that, gosh, is that even really the same intervention when you make that kind of shift? Although we were recruiting from multiple locations in Northern California, this was all still based in Northern California. This was also a study where we weren't recruiting women with major mobility impairment or complex urologic histories or neurologic histories, and it's possible that those women would have responded very differently to these programs. And then finally, I should say, fundamentally, this most recent LILA trial, it's not a study that can directly compare the effects of pelvic yoga to no intervention at all. But, in terms of our overall findings, I think the findings do suggest that ambulatory women with frequent urinary incontinence across the aging spectrum and from multiple ethnic backgrounds, they can be recruited, engaged, and taught to practice pelvic yoga safely. Age, maybe more than ethnicity, was more closely associated with sort of participants' self-efficacy and practicing the physical aspects of yoga. Both of the interventions in this trial were associated with a more than 50% average decrease in continence frequency of any kind over 3 months. But ultimately, pelvic yoga was not clearly superior to a general muscle stretching and strengthening program in reducing clinically important incontinence in women who had daily incontinence to begin with. And this suggests that any potential benefits of yoga for sedentary aging women with incontinence are potentially shared with other types of physical movement-based interventions. So just want to say thank you, of course. Thank you to one of our collaborators, both ones at the Osher Center and based elsewhere. Thank you to multiple NIH institutes or centers that contributed funding to this research along the way or to some aspect of the research. And then, of course, huge thanks to the women who took part in these studies, who gave their time, their effort, our data made this work possible. Thank you.
Thank you, Dr. Huang, for this great talk. I'm going to kick us off with a question that came in the chat, and then other people can be collecting your questions and share them out loud or in chat when you're ready. So one question that I got was about whether you collected data on number of births and or prolapse diagnoses or histories among people who were participating and whether that affected anything about the intervention.
Great question. Yes, we did. We did ask women at the beginning of the study about their childbirth history. The majority of participants had had at least one prior childbirth event, I think. And I think that there were some that were multiparous, and there were some who had not previously had any childbirth events. I don't think we've yet explored whether the impact of the program was greater or lesser among women based on their past childbirth history. It might be an interesting thing to explore. Thanks for bringing that up.
Thanks.
I guess I see a hand up from Ashok Varma.
Yeah, thanks. Very interesting topic and very informative. I'm a physician, and I was wondering if the same things can be applied to men with urgency and basically incontinence.
Yeah, great question or suggestion there. Yes, this study focused on women, and there was a sort of thought that pelvic floor yoga might offer greater benefits for women in whom urinary incontinence is a little bit more likely to be linked with pelvic floor weakness. So, the bladder in women gets support from the pelvic floor, and childbirth events and other things are more likely to cause pelvic floor weakness. And so to the extent that that's a specific issue in women that leads to women having a more than twofold greater prevalence of urinary incontinence compared to men, it was thought that maybe pelvic yoga would be especially helpful. But, now if we say, I don't know, if we believe the trends we see in this trial, that urgency incontinence, overactive bladder maybe was more meaningful in terms of responding greater to pelvic yoga than to physical conditioning, we might say, well, that intrinsically is, that men have overactive bladder as well, and perhaps, for a similar rate, should we explore it? And I'll say broadly for physical exercise, I think it's if we think that at heart it's really just about physical movement for people who become more sedentary or deconditioned and have maybe worse sort of autonomic nervous system balance related to that, good to explore that in men as well. I'm working with or contributing to work that others at UCSF are spearheading to try and explore exercise-based interventions for older men with lower urinary tract symptoms that are usually attributed to prostate issues. This is Scott Bauer and Stacy Kenfield, where similarly this idea that should we be thinking about more pleiotropic interventions that can address other multifactorial contributors to bladder control?
Thank you.
Thank you.
While other people get ready to share their other questions. I'm curious if you can tell us more about what the next steps are for this line of research.
Yeah, it's a good question. So, we are still in some ways just trying to finish up our reports and disseminate our findings, right? Hopefully we're not far from having an accepted paper that would present our initial primary urinary incontinence outcomes. There's quite a bit to explore here, these data though, and with collaborators, I think we're hoping to look at changes in some of the other measures in this trial and how they relate to changes in incontinence and how they change with the interventions. So I probably went through this very quickly, but participants did go through some simple physical performance measures, balance testing, chair stand testing, aerobic step testing, and we want to explore how those change and how those changes do or do not track with changes in continence. Participants completed sleep diaries in addition to their bladder diaries. They completed questionnaire measures about sleep. They completed questionnaires about depression and anxiety and perceived stress symptoms. They, some of them, not all of them, the pandemic sort of interfered with this somewhat, but some of them had pelvic floor exams where we did digital pelvic floor exams to sort of assess pelvic floor muscle tone and contraction strength. Some underwent measurements of cardiac autonomic function. So underwent heart rate variability studies, cardiac impedance studies for us to measure pre-ejection period part and how these change with the intervention. So I think first, actually, we have a lot to explore there that might guide what might come next. I think it's very possible that we may want to explore yoga in combination with other kinds of interventions as well. So I think this question of like, what are the components of the interventions that are really helpful, that make a difference? What is unique? What is shared among interventions is an important one. And let me just say on top of what I said, if those of you listening today, if some of you are researchers interested in pelvic health, yoga, and the kind of measures that I've brought up are interesting to you, and you are interested in contributing or even helping to spearhead analyses or reports or manuscripts based on these data, I hope you'll reach out. And maybe there's ways that we could work together. We really want to make use of all the rich data that we ended up collecting from our participants. I think I see Francesca is adding, yes. So one thing I didn't mention is that to explore sort of the women's participants' perceptions of their lived experience of learning to practice yoga. Interviews were conducted by Francesca and also another colleague to ask all kinds of questions about their experience with online yoga and what it was like to kind of embodied experience of learning to practice yoga for a pelvic health issue. And that is something that Francesca has already gone into, but there may be more to explore there also. I see a question for someone. Oh, curious if Dorothy Chu, curious now if there's an option to go back to in-person classes, if you think you would do in-person versus Zoom for intervention delivery. Would you? So it's a great question. I think, ideally one would do a study, right, where you plan out delivering an intervention in person for some and delivering it online for other, and really like randomly assign people to have one kind of experience than another and compare their experience. I do think it's an important question, what is or is not lost with the shift to online delivery. I realized that something important I should have mentioned, which is that we did do a simple sort of interaction testing, subgroup testing to see, does the intervention look more potent when in our study when it's delivered in person rather than by video conference. And the result of the interaction test was non-significant. Interaction tests, like sometimes you simply don't have the power though really to test your hypothesis about whether the potentially greater benefit of pelvic yoga versus physical conditioning depends on whether classes are taught in person versus online. I think we certainly had a concern or a question for something like yoga, where many, people do feel like, oh, there is a benefit from being in person, from having an instructor lay hands on you, for example, from being able to reposition you, that is lost when it's delivered online. But it's all speculative, I'd say. Like perhaps we wouldn't find that. Perhaps we would find in person people can't make it to their classes. They drop. They miss more classes, and so they don't get as much benefit. They're not practicing as often. I think there is reason to believe that just some folks would not engage at all if they had to travel regularly to a yoga studio or space, who would be willing to engage, right, from the comfort and security of their own homes, and in a setting where they feel reassured, like, oh, they had your leakage episode or something, they don't have to worry about like trying to find a public bathroom, for example.
One other question that came to me in the chat is whether you think that mindfulness non-exercise control would be useful as a comparison, given the findings around urge incontinence and yoga.
I think it's a great question. So there are other kinds of complementary treatment approaches that are of interest or being explored for issues like overactive bladder, mindfulness, or just separately like hypnosis. Like I think there are a lot of potential complementary approaches to consider that maybe don't put so much emphasis on the physical, are putting more emphasis on the mental, emotional, and/or spiritual.
Well, we're coming up to the top of our hour, so I think we'll
Yes,
let
thank you all so much
go.
for your
Thank
time and
you so much,
attention.
Dr. Huang. Folks are welcome to come on video for a minute if you want to, or virtual applause. Really appreciate you taking the time to come talk with us and inviting people to collaborate in the future.
Great to talk to you.